uh, several speakers today that are sharing the session. It'll be very interesting. But first, I'd like to do a little bit of housekeeping. Thanks to Rachel Fowler for setting all this up. She's our coordinator for this meeting. And she may have some comments about CME and maintenance of certification here in just a second. But then after that, we'll talk about some housekeeping items. Would you like to comment, Rachel?
Yes, sir. We will put the slide where you can text the number with the code at the end of the presentation if you weren't here to get it at the beginning. Thank you.
Thank you, Rachel. And that's a reminder, we now have our continuing medical education handled through a website at Baylor College of Medicine, but the maintenance of certification is continuing to be handled by UTMB, and those instructions, as Rachel said, will be at the end. So as far as housekeeping items go, we request that you please keep your microphones on silence. Please disable your video as well. Sometimes it interferes with the bandwidth of the speaker. We also are not able to troubleshoot individuals who are having difficulty with reception. We have tested this remotely, and our signal is strong, so we'll have to leave it up to you to settle any issues you're having with reception. So usually we save questions till the end of the presentation, but I'll leave it up to the speakers to say what they would like as far as entertaining questions. And so with that, we will be very pleased to hear a presentation today on women's health, management considerations in the space environment. This is number 2 in a 2-part series on this topic. We're very happy to have Dr. Rebecca Blue, Dr. Jonathan Steller, and Dr. Chris Zahner presenting today. And with that, I'm going to give you a quick rundown, a little introduction for each of them, and then I'll turn it over to our speakers. So Dr. John Steller is Assistant Clinical Professor of Maternal and Fetal Medicine at the University of California, Irvine. After obtaining degrees in neurobiology and classics at the University of California, Irvine, he completed medical school and residency in obstetrics and gynecology at the University of California, Irvine as well. He recently completed a fellowship in maternal and fetal medicine at the University of Colorado. His past research has focused on the use of ultrasound in primary care and obstetrics, including improving the sonographic triage of fetuses affected by intrauterine growth restriction through evaluation of novel cerebral and umbilical circulation measurements. However, his main research focus lives at the intersection of space medicine and reproductive health. He's currently working on projects assessing the risks of long-duration spaceflight on the gynecologic and reproductive health of our astronauts, as well as evaluating the effects of chronic low-dose neutron irradiation on reproductive outcomes in mice. And Dr. Rebecca Blue is a physician specializing in emergency medicine and aerospace medicine. She serves as a flight surgeon under the UTMB KBR Human Health and Performance Contract at NASA Johnson Space Center, where her current role includes supporting commercial crew activities and the Human Landing System program. She's a contributor to many areas of operational research with interests including crew survivability and threats of the high altitude environment, mishap preparedness and response, and evaluation of commercial spaceflight passenger tolerance of acceleration forces. In addition, she has been heavily involved in the research, development, and integration of medical systems for exploration spaceflight environments, with efforts including study of space radiation health risks, pharmaceutical stability in the space environment, and women's health considerations for long-duration spaceflight. And she's also a graduate of our aerospace medicine residency program. Dr. Christopher Zahner is the Clinical Pathology Division Director at the University of Texas Medical Branch. He serves as physician under the UTMB KBR Human Health Performance Contract at NASA Johnson Space Center, where he supports Exploration Medical Capability Section. Prior to medical school and residency, he was a mechanical engineer for NASA in the engineering and operations contracts for the International Space Station, specializing in environmental control and life support systems, that's ECLIS. In that role, he was lead engineer for the Waste and Hygiene Compartment, or the WHC. So with that, as you can see, we have a distinguished group of speakers this morning, very interested to hear their presentation. With that, I'm going to turn it over to you. Thank you, folks.
Thank you very much. Can everybody hear me okay?
We can.
Great. Okay, so thank you guys all for your time and attention today. I am very fortunate to be able to share this presentation with Dr. Steller and Dr. Zahner, who have put an enormous amount of effort together to help me pull this information together. I'm going to share my screens. Give me just a second so you can see my slides. Okay. And please let me know when you can see the slideshow.
It's up.
Great. Okay, I'm going to kill my camera so I don't slow down the streaming here. Hopefully that works. Okay, so today we're going to talk about a number of topics in women's health. If you were able to attend last month's presentation, Dr. Steller gave us a great rundown of some of the gynecological considerations for future spaceflight and a lot of information about his prior research. Today, we're going to go a little more into specific details on a few of the following topics. Specifically, There we go. We're going to talk about management of gynecological considerations in spaceflight, specifically in choice of hormonal modalities, use of hormonal modalities, or avoidance of them in the space environment, some of the risks and benefits, choosing an appropriate contraceptive or suppressive technique if that is desired, the effectiveness of such, some considerations for how to make such a choice, provision of hygiene products, where some of the numbers come from and some of the implications for future exploration, waste management and water reclamation, and how the waste management systems work and how all of these things tie together. I'm going to start off first by letting Dr. Zahner take the lead, or excuse me, by letting Dr. Steller take the lead to talk a little bit about spaceflight and gynecology.
All right, can you guys hear me okay?
We can.
Perfect. All right, thank you guys. So we touched on some of these gynecological topics last time, and as Dr. Blue said, we're gonna sort of weave in how we think the interplay of hormonal modalities sort of affects that, and how all of these other considerations weave in. And so, really at the start of things, there's very little known about how the space environment itself actually affects normal, gynecologic and reproductive physiology. We don't have a lot of information on how it can affect normal menstruation in the absence of hormones. We don't have a lot of information about how it could affect fertility, or how the spaceflight environment itself in the absence of hormones may affect gynecologic pathology, such as abnormal uterine bleeding or anemia or bone mineral density, VTE risk, ovarian cyst production risk, or cancer risk. And then on top of that, it's difficult to know if you add hormones into that equation. There's also not a lot of information on how that can modify any of those risks, and that's largely because we haven't documented those outcomes that well. So there have been some limited studies trying to assess how surrogates of the spaceflight environment could affect some of these. There was a bed rest study that was done a long time ago that tried to see if that affected menstruation, and it was found that it did not. And then there's some new studies that are being done with Dr. Bloomfield's lab, where they're looking at hind-limb unloading in rats and seeing if that alters estrus cycling. And as far as the first 1 to 2 studies goes, it looks like that it may alter some of the timing of estrus cycles in rats, but that's also short duration hind-limb unloading. And yeah, next slide, Becky. So when we think about the different hormonal modalities in the spaceflight environment, we think of the same ones that we have terrestrially. So there's combined oral contraceptives, which have estrogen and progesterone. There's progesterone-only pills, combined hormonal transdermal patches, combined hormonal vaginal rings. There's a levonorgestrel, which is a form of progesterone intrauterine device. There's etonorgestrel, which is another progesterone subdermal implant that can go right here under the skin in the arm. And then there's the intramuscular depomedroxyprogesterone, which is another progesterone only. So all of these hormonal modalities, they come with varying pregnancy prevention rates, amenorrhea rates. Amenorrhea means like the absence of your menses, as well as individual risk-benefit profiles, which differ depending on one's physiology. They could also differ depending on like the type of hormone or the dose of hormone or the duration of how it's used, or whether it's used continuously or cyclically, where you have a withdrawal week. Next slide. So, importantly, astronauts have the autonomy in selecting this strategy. If they wanted to use any of these modalities, or if they want to use none of those modalities. And all the things that come into this consideration for astronauts and their teams as they're thinking about whether or not to use any of these modalities or which one is, how does it affect menses? Does it alter the bleeding profile risk? Does it lead to menstrual suppression partially or completely, which would be amenorrhea? What is its contraceptive efficacy? Can it be helping modify some of these other risks like we talked about, such as ovarian cyst production or bone mineral density or things like that? And what sort of side effects can one experience with those, or what sort of complications can arise in the setting of those? And so I think we should delve into those considerations a little bit more. Next slide, Becky. So historically, the majority of astronauts have either used combined oral contraceptive pills or the levonorgestrel IUD continuously. And while combined oral contraceptives require remembering to take that pill every single day of the year, they have the highest amenorrhea rates at 1 year, upwards of 60 to 88% based off terrestrial studies. Amenorrhea rates for the levonorgestrel IUD peak around 60%, which would make that second best, but that doesn't require daily compliance. The levonorgestrel just needs to be placed one time and can be in place for 5 to 7 years. With both of those modalities, there can be some abnormal spotting in the first 2-3 months of use, and then amenorrhea rates tend to escalate from there, where there's more and more suppression and improvement in a bleeding profile. So the goal of these birth control modalities has always been to prevent pregnancy rather than to prevent menses. And so amenorrhea has always been more of a side effect of birth control modalities rather than an endpoint. There hasn't been heavy interest in evaluating long-term amenorrhea rates in the literature. So a lot of our best studies of actually looking at amenorrhea rates just come after 1 year of use. However, there is good safety data to say that continuous use of these hormonal modalities is safe, and there's actually growing data that women internationally may desire amenorrhea following counseling of the safety profiles. So there is some hope that the pharmaceutical industry may consider the development of modalities at some point that not only optimize pregnancy prevention, but also long duration amenorrhea rates, as this may be desired by many women in aerospace, in military, or just in general terrestrially, if they choose, right? It would be, if they have the autonomy to choose that decision. So while the subdermal implant has been reported in spaceflight, the other combined modalities like the transdermal patch or the vaginal ring have not been reported. Either is dipomedroxyprogesterone. Next slide, Dr. Blue. So, regarding actual, let me see here. Apologize for my slide. So when looking at these different modalities, with perfect use, all of them approach 99%. However, with typical use, in terrestrial studies, a lot of them sit somewhere in the 90s. And in studies that have actually tried to incentivize people in order to use combined oral contraceptives with perfect compliance, they've found that that 83% of the participants in those studies were able to comply with daily use of combined hormonal contraceptives for the duration. 83% effectiveness there is a little bit of a misnomer. It's not that the contraceptive was 83%, but that even when incentivized, there was 83% of study participants that can actually follow that regimen with perfection. And so when thinking about in the spaceflight environment, while we think that we could be higher than 83% effective, there are always going to be factors that could adversely affect daily compliance, such as circadian shifting or busy operational schedules or mission critical events. Importantly, I think it is to note that the things like the levonorgestrel IUD or the subdermal implant, because they don't require that perfect daily compliance, they're just placed one time, and with the implant it can last 3 years, and with the levonorgestrel IUD 5 to 7 years. The typical use essentially equates perfect use. Go ahead, next slide. So when thinking about some of these medical considerations, we talked a little bit about abnormal uterine bleeding last time. So abnormal uterine bleeding may be the most common gynecologic pathology to consider terrestrially. Almost 1 out of every 4 women would experience abnormal uterine bleeding at some point during the reproductive time period. We think of the abnormal uterine bleeding by the acronym PALM-COHN, where there's structural causes and there's non-structural causes. Structural causes that can lead to abnormal uterine bleeding would include polyps and adenomyosis, leiomyomas, which are fibroids, or endometrial hyperplasia or malignancy. And the non-structural causes would include things like coagulopathy or ovulatory dysfunction, with ovulatory dysfunction probably being the #1 cause of abnormal uterine bleeding when considering all of these things. Interestingly, not only can a lot of these hormonal modalities help improve the symptoms for these various structural and non-structural causes, but after treatment of either some of these structural causes, these hormonal modalities would be the best prevention of recurrence. Next slide. So the anemia incidence, independent of contraceptive use in reproductive women, terrestrially is about 10%, and that's defined as having a hemoglobin less than 12. And the most common cause of that would be iron deficiency. And when you're looking at a complete blood count, we're often looking at the mean corpuscular volume to see if that's less than 80, which would mean that the red blood cells are small, and looking at their actual ferritin as a surrogate for their iron stores. In the absence of anemia, iron deficiency itself can also be associated with weakness or fatigue or difficulty concentrating. In spaceflight, there has been an association between physiological adaptation to microgravity with a decline in red blood cell mass, a decrease in circulating erythropoietin, but menstrual associated anemia has not been identified. Next slide. So when thinking about menstrual suppression with anemia and iron deficiency, we know that menstrual suppression through hormonal modalities actually can reduce the risk of anemia terrestrially. The levonorgestrel IUD has actually shown to stabilize or even elevate iron stores after 1 to 2 years of use. And we know that by using hormones in a suppressive modality, if you have decreased menstrual blood loss, then obviously you're going to have decreased rates of amenorrhea and an improvement in iron stores. There has always been some concern about how transferrin relates to this, and whether there could be an increased risk of ischemic stroke due to the upregulation of transferrin inducing hypercoagulability. However, that data is fairly controversial. And could we consider increasing screening for iron deficiency prior to spaceflight? Absolutely. So VTE. Some of the main risk factors that we associate a spaceflight with VTE would be there is microgravity-induced blood flow stasis. There's decreased lower limb mobility. There's altered fluid distribution. There's increased stress, and there's immunosuppression. Oop, one slide.
Sorry.
That's okay. And there's the thought of, does endogenous or exogenous estrogen also potentially increase that risk of VTE? So terrestrially, the VTE risk on hormonal therapy is about 4 to 6 times higher than baseline reproductive age females not using hormonal contraception. And that risk goes up with the higher dose of estrogen used. Some pills can go all the way up to 50 micrograms. Historically, we've used 30 to 35 micrograms. That VTE risk goes up during the first 3 months of use, but actually that while that risk spikes, it sort of like tails off with longer use after 3 months. Historically, when we think about the different generations of combined oral contraceptives, which really refers to like the newer progestins that was combined with ethinyl estradiol, they've seen that multiple types of the progesterone in the 3rd generation or 4th generation combined oral contraceptives, which are the newest, may have slightly higher risks of VTE in it above 1st and 2nd generation combined hormonal contraceptives. The 2nd generation is mainly levonorgestrel as the progestin. And then there's conflicting data in the literature on how the risk varies between the different combined hormonal contraceptives. So when thinking about COCs or the ring or the patch, it was historically thought that because the ring and the patch are avoiding first pass metabolism, through the liver, that after being absorbed, through the gut, that maybe there was slightly lower VTE risk. But now there's some evidence that has seen higher VTE risk with those, and questions whether even though it's a lower dose, that because it's like a continuous infusion to the bloodstream, that like maybe there could be higher risk. So the data sort of is conflicting there. But certainly most of the time when we're concerned about VTE in the setting of hormonal contraception, there's other exacerbating risk factors such as thrombophilic disorders. Next slide. So recently there was the first published case of a thrombosis during spaceflight. And you could see one of the quotes from that article by Marshall Goebel there. I think some important key points, though, to remember is that there's been extensive use of hormonal supplementation during spaceflight for all of these years, and there's been no evidence that hormonal supplementation has directly contributed to the development of VT, nor has there been a clinically significant VTE to date. Right? It was almost incidental. I think what's important that this article highlights is that there is also alterations of venous flow observed in both male and female crew members. Next slide. All right, so ovarian cyst and complications. So the baseline incidence of ovarian cysts in reproductive age terrestrial populations is about 5 to 7%. And in a historical study where we looked at ovarian cysts pre-flight in all ass cans, it was 5.7%, which is about equal with the terrestrial rate, as we'd expect. The majority of all those cysts are simple, less than 5 centimeters, and generally physiologic. Cysts that are greater than 5 centimeters and are considered complex ovarian cysts, which means that they might be multiloculated or have some cystic and some solid components, or papillary excrescences might be at higher likelihood of torsion, given that they could be off balance and make them at higher risk of twisting, as well as maybe more likely to be abnormal and concerning for cancer. Ovarian torsion in spaceflight has not been reported. And evaluation for ovarian cysts in spaceflight has also not been reported. Combined hormonal contraceptives, which can lead to pituitary suppression and ovarian suppression, will thus suppress ovarian cyst production and mitigate that risk. Next slide, Dr. Blue. Osteopenia is another important consideration, and especially when we're considering the use of hormonal modalities, because we know that astronauts lose about 1% of bone mass per month during spaceflight. Furthermore, we can utilize resistive exercise or vitamin D or bisphosphonates all to help mitigate that bone loss. But another main driver of potentially improving bone loss based off of terrestrial data would be that combined hormonal contraception that mainly uses estrogen can show some improvement. and decrease risk of bone mineral density loss. However, in one study of looking at oral estrogen to see how that affects bone mineral density after 39 days of Heinlein loading, they didn't see a protective effect in that newest study. However, there's a lot more work to be done there. And I think, as a reminder, I think inconsistent with the black box warning for depot-medroxyprogesterone, that it's associated with significant bone mineral density with long duration use terrestrially, which is likely why it also has not been used in spaceflight. Next slide. So regarding cancer, the lifetime cancer risk and cancer-related mortality in terrestrial women is 27% and 18%. One out of eight women get breast cancer. It's the most common cancer amongst women. Breast and gynecologic cancers have not been found to be increased in astronauts looking longitudinally. And we know that the hormones play a role in this as well, that combined hormonal contraceptives reduce the risk of ovarian cancer, endometrial cancer, and colorectal cancer. And there's some evidence that long or levonorgestrel IUDs may also reduce some of these risks as well. Combined hormonal contraceptions, though, do slightly increase the risk of breast cancer. Really, you see that risk spike while using those, and the further you're out after discontinuation, that risk goes down. Also, it seems that some of the different formulations of the combined hormonal contraceptives would be associated with some of that higher risk. However, the same goes for cancer-related mortality with these. You could also see that combined hormonal contraceptives would decrease cancer-related mortality of some of these more severe gynecologic cancers like ovarian cancer, whereas while breast cancer incidence may be higher, it's not as deadly of a cancer as like ovarian cancer. All right, next slide. Last few from our perspective. So in consideration of SANS, obviously one of our main drivers is also the prevention and management of SANS, or the associated elevated intracranial pressure. There's been a few studies or case reports that have reported an association between hormonal modalities and idiopathic intracranial hypertension. However, these studies only showed association and not causation. We already know that, just in the terrestrial literature, that IIH most frequently occurs in women of reproductive age. And thus, that's the same population that's at highest risk for developing IH is also the same population that, is most likely to be using contraceptives, which can lead to some bias in that association. However, while 17 million women in the U.S. are using hormonal contraceptives, the incidence of IIH is 1.8 per 100,000. And multiple studies have found, trying to look at directly at correlation leading to causation of IIH and hormonal contraceptive use have failed to show that. And so there's no evidence that hormonal supplementation actually increases the risk of intracranial pressure. And I think the last thing to remember about SANS there is that we think that there's a decreased risk in women compared to men as well. So with contraceptive associated complications, there's always the fear that an IUD can migrate after placement. Perforation occurs less than 1 out of 1,000 times. The vast majority of perforations, though, are thought to occur during the time of placement, and we can see that perforation rate decreases when use of ultrasound guidance is performed in order to place it. And so really, while there can be some migration of the IUD, the majority of the movement that may occur is downward, from the fundus of the uterus down towards the cervix. And most often when it moves during that first month of use. So, terrestrially, we think that there's a fairly low risk of migration or perforation after those time periods. So, when inserting it under ultrasound guidance and inserting it, multiple months before the possibility of space flight, we have very low concern of perforation or migration occurring. Furthermore, it hasn't been reported in spaceflight to date. And so, another thing to triage whether it's in the right place afterwards is whether you could just use bedside ultrasound to take a look at that, or also because there's strings attached to the end of the IUD. Those strings are often passing through the cervix and then sitting in the vagina, so you can always, check for those strings to make sure that those are there. And if there was ever the concern for, some like the IUD implanting into the wall of the uterus, or that it's moved downwards and is uncomfortable, you can always triage that if the strings are present by just pulling on the strings and easily removing the IUD. The rare scenario would be that if there's concern for migration or perforation or other complications from the IUD and the strings are up in the inside, then in the spaceflight environment, that would just have to rely on supportive management. The incidence of that would likely be very low, especially with also just cutting the strings long to decrease the chance of that happening. Next slide. And as far as that's a picture of an Nexplanon or the subdermal implant in the arm. The migration rate after placement of those is 2.6 per thousand. And it's often, if it does migrate, it's only within 2 centimeters of where it's placed. About 6% of them are difficult to remove 3 years after they're placed. And that may be because of its placement too deep within the subcutaneous tissue rather than just under the skin. So it's a placement complication, not a migration complication generally. When it does move, it often moves towards the level of the axilla. And ultrasound could always be used to help locate it, to help facilitate removal when it's time. Lastly, actually, you guys do this section, Dr. Blue?
Yeah, I can certainly speak to this. So one of the things that we wanted to do in this presentation is start to demonstrate some onboard trades for mass and volume considerations. When we talk about all of these modalities, clearly there are a number of factors that we want to consider when discussing appropriate choice. And, the major driver, of course, is crew member autonomy and their ability to weigh in on that decision. However, it is worth at least looking at comparative packaging, comparative mass considerations as we start planning towards longer and longer missions. Here are just some basic numbers comparing the number of IUDs, implants, rings, patches, and pills that one would need for a 1-year or 3-year mission going forward into longer duration spaceflight. So 1-year mass considerations here, 3-year totals over here. Unfortunately, we were unable to obtain an estimate of actual ring mass for the Anavera or the Nuva ring, but we anticipate that they're somewhere around 20 grams, so you can kind of do the math in your head and get an understanding of what the comparative volume and mass would be for each of these modalities. I'll come back to this slide in a minute because there's more to weigh in here. Let's switch gears for a minute and talk a little bit about pharmaceutical use. NASA does not currently pursue the collection of comprehensive data regarding pharmaceutical use, effectiveness, or shelf life in the space environment. We do know that somewhere around 80% or more of the medications currently flown on the ISS formulary have expiration dates somewhere around 12 to 24 months after they are flown. And this does not account for, after they are put on the shelf, this does not account for lead time, packaging and preparation, and launch. Most medications will not remain acceptable by terrestrial standards for long duration spaceflight missions greater than 12 months, particularly when we add in the factors of outside of low Earth orbit, for example, increased radiation exposure. Resupply may or may not be available for future missions. We need to start thinking about the shelf life and availability for some of these longer term treatment necessities. What I'm showing you is a graphic from a 2019 publication where we looked at all of the various flown medication studies. What you can see here in the study highlighted here in dark blue, due 2011, did include a study of an onboard combined hormonal contraceptive, progestin estrogen dosing pill. This medication was flown and returned with ground-controlled comparisons at the timestamps of 14 days of spaceflight, 353 days of spaceflight, 596 days, and 880 days. At each of those time points, the medication was compared back to ground controls that were maintained in a comparable temperature, pressure, and humidity environment. What this study identified with that particular medication was that at the timestamps of 596 days and 880 days flown, the active pharmaceutical ingredient in the progestin-estrogen combination medication was found to fall below acceptable USP standards for active pharmaceutical ingredient. However, at both of those timestamps, the medication was also exceeding its shelf life. So it is unclear, with only 4 time points in the study, whether or not this failure of API was associated with shelf life, exposure to the space environment, or any or all of the above factors. There are no other studies of flown hormonal modalities in terms of shelf life stability or API. We do not understand the impact of space radiation. We also only have anecdotal reports of effective suppression and flow similar to terrestrial experiences. There has been no effort to study regimen adherence or report on actual flow or medication effects during spaceflight. It's also worth noting that, as I mentioned, again, NASA does not pursue detailed or comprehensive reporting of medication use, schedule adherence, or anything associated. In 2017, there was a project called Dose Tracker that studied the actual usage of medications during spaceflight. This study compared back to previous reports during expeditions 1 through 20 and expeditions 21 through 40, where crew members voluntarily reported the use of medications during spaceflight. During expeditions 1 through 20, crew members on average reported 12.6 medications used during an entire mission. During expeditions 21 through 40, where crew members were further encouraged by their flight surgeons to increase their reporting, a total average of 23 medications per mission were reported. During the Dose Tracker trial, a bar scanning method was used every single time a medication was distributed. And in the 5 crew members that fully reported data, on average, 453 uses of medications per mission were reported. The conclusions indicate not that participating crew members were using more medications, but that medication usage and reporting has been grossly underreported in medical documentation during flight. And I point this out not just to highlight, schedule adherence or reporting issues, but the fact that we have not pursued these data, and as a result, data to inform some of these decisions is just lacking. I'm going to switch gears a little bit and talk about hygiene product provision. A lot of you have probably heard this story. Sally Ride gave a great interview where she discussed the provision of hygiene products for her 1-week spaceflight. This is an excerpt from an interview that she gave where she noted that engineers offered her as much as 100 tampons for 1 week in space. And she was surprised by their generous allocation of products. And while we all have, laughed at this story and we refer to this as something silly, it's worth noting that these numbers came from somewhere. So let's talk about where they came from. Starting with menstruation basics, the average volume per cycle for most women is somewhere in the order of 80 to 87 cc's per cycle. There's a wide range of normal. Multiparous women tend to bleed a little heavier than nulliparous women, with average output closer to 95 cc's per cycle. However, again, there is quite a wide range of normal. 65 to 70% of that output is blood products, 30 to 35% is mucus and cells. On average, flow is around 0.76 grams or cc's per hour of blood, 0.3 grams or cc's per hour of secretions, and there is higher flow in the first few days of output. When we look at some of NASA's resources for where numbers for design, planning, and engineering come from, the Human Integration Design Handbook estimates 113 cc's per person per day of menstrual volume for as much as 4 to 6 days of a cycle. For a 6-day cycle, that is an estimate of 680 cc's output. You can see the wide overestimation here of output. Now, there are a lot of, off the record statements that this is probably, that this is probably an overestimation, and it's not that we necessarily protect to almost 3/4 of a liter of output in our actual design, but it is worth noting that our references state that this is the estimate output. These numbers further inform the NASA Baseline Values and Assumptions document, or the BVAD. Here I'm referencing Rev 1, published in 2018, that states that menstruation will occur once every 26 to 34 days for a duration of 4 to 6 days. Mean estimated tampon or pad usage is 16.2 products per crew member per day, according to the VVAD. For a cycle then lasting 6 days, this is an estimate of 97.2 hygiene products per cycle. That is an estimated product change every 1.5 hours. Again, this is a fairly heavy overestimation of what actual usage is. If we look back at the citations from the actual BVAD documentation, looking back to this Parker and Gallagher here noted at the table bottom right, in 1992, the Parker study published actual quantitative usage of products during menstrual cycles in a number of women and noted an average use of 16.2 products per cycle. At maximum, this paper noted at maximum product usage was 35 per cycle. The Parker additionally cited in another paper that did a similar approach to quantifying actual usage during a menstrual cycle and similarly noted a maximum usage of 34 to 35 products per cycle and an average around 15. So if average products per cycle is 16.2, it is unclear whether the transcription of these numbers into the HIDH or the BVAD was an intentional overestimation or a simple transcription error, but we see that average cycle usage has been reported here as average daily usage, which leads to some of these gross overestimations. So what does this actual do? When we actually look at what this does when propagated over an entire long duration spaceflight, 16.2 products per day is 97 products per cycle. The BVAD reports an average unused dry product mass of 6.4 grams. 16.2 products by 6.4 grams per product is 100 plus grams per day of dry waste anticipated for every day of the cycle. So one question is this reasonable? When we look back at analog studies, I'm looking towards the High Seas Mission 2, which was an analog study of 120 days in Hawaii, simulating a Mars terrestrial analog. In that study, dry waste was actually collected, or excuse me, total waste, used waste was collected. That included toilet roll, toilet paper, floss, and feminine hygiene products. And on this mission, it was averaged that 60 grams total waste per crew member per day was reported. I don't have specific information regarding sex-specific breakdown of this product usage. I don't have any information regarding whether women, there were 3 women on this mission, it's unclear whether they had any sort of menstrual suppression. But as you can see, even average total waste used is 40% lower than expected dry hygiene-only waste by these numbers. For longer missions, if we're talking about unsuppressed cycles every 28 days, 13 cycles per year, 13 cycles, 97 products per cycle, 6.4 grams per product for a 1-year mission amounts to 8 kilograms of onboard sanitary products per female crew member. If instead we look back to the Parker and associated studies where maximum usage reported was 35 products per cycle, let's up that to a conservative estimate of 40 products per cycle for an average of, when we are talking about an average of usual use of 16.2 products per cycle, again, this is a heavy overestimation. If we plan towards 40 products instead of that 97 per cycle, this is a greater than 50% reduction of only 3.3 kilograms of sanitary products per crew member. So I've added a line here to the table you've seen before regarding hygiene products. Again, Onboard mass and volume should not be the only consideration when we talk about use or avoidance of hormonal supplementation. But when we start talking about how this affects our onboard mass and volume, using more realistic numbers leads us to far more appropriate mass and volume estimations than using some of the numbers that we've planned to in the past. Again, you can see here the average that comes from using BVAD numbers for a 3-year mission amounts to 24.2 kilo per crew member versus 10 kilo for a 3-year mission per crew member using conservative but more quantitatively based numbers. Here we're going to switch gears again, and I'm going to pass the mic over to Dr. Zahner to speak a little bit about waste hygiene and water recovery.
Thank you very much, Dr. Blue. Can you hear me?
We can.
Okay, wonderful. So we wanted to discuss some of the current states of ISS waste and urine collection systems. We recognize that future design vehicles haven't been totally built. Obviously, there's all kinds of considerations to be made, but an understanding of current systems is probably a good starting off point to discussing the benefits and limitations of these future systems. Obviously, specifically to our discussion today, we want to know how the management of menstrual flow might affect the engineering design requirements of these future systems. What you can see here is the WHC, which is a piece of hardware that's near and dear to my heart. It flew on STS-126 in 2008. And of course, we recently launched the WMS in 2020. Next slide, Dr. Blue. And what you can see here are the WMS on the right and the ASU on the left, the Russian ASU. Prior to launching of the water recovery and management system and the WHC, the ASU on the left did all of our heavy lifting for waste collection. Unfortunately, all of that urine was simply discarded on progress mostly. The system itself is fairly robust, and its robustness is why we used it almost exclusively for the WHC. It's really almost identical to the WHC system. All of the hardware is simply purchased from Energia. So those systems are redundant for almost everything, and the WMS is actually fairly new hardware. Next slide, please. And what you can see here is some of the challenges that Dr. Broyan and team articulated in the design phase for a waste collection system. And as a result of some of these difficult challenges, it's hard to process 3-phase material in space. Air, liquid, and solid mixtures are just a challenge. And those systems oftentimes get clogged up, they can fail, and so it has been the practice of the agency to try and use legacy hardware whenever possible, which is why we thought it would be so instructive for us to discuss the current hardware on ISS, because we believe that future systems are likely to be based on these current designs. Next slide, please. So the WHC, like all waste collection systems to date, uses negative pressure for collection, both of urine and solid waste products. That's not true. Some of the systems did not use negative pressure for waste collection, but almost always did for urine collection. What you can see is on the right side of this image, the urine funnel, at the top right, the yellow. Urine is collected into the funnel, goes down the tube, and is mixed with pre-treat fluid and flush water, and then goes into a rotary drum pump separator assembly. And out from there goes into the WRM system we'll talk about later. The solid waste is far easier. We just have a fan essentially connected by that tube on the left side of the collection tank. and it provides negative pressure, and the solid waste goes into the canister, and when it's full, we just cap it and discard. No processing of that. Next slide, please. And so the urine moves from the WHC into the WRM system, and the WRM, water recovery and management, or water reclamation and management system, is two systems that are housed in two racks. The first system, the urine processor assembly, is in WRS2, so it's sort of backwards, and it's about half of that rack. And then the remaining, the WPA, water processing assembly, is in half of WRS2, and then the remaining is in WRS1, so it's sort of backwards. And the way it works, sort of collectively, is the urine goes into a tank at first, and then it goes into the assembly that you can see here, the distillation assembly. And that distillation assembly utilizes a fairly high delta negative pressure to evaporate the water from the waste urine, and collects wastewater on one side of the assembly and leaves the concentrated pretreated urine on the other side. The concentrated pretreated urine, or brine, goes and is collected into the RFTA, and the wastewater then flows into the WPA. So this is the somewhat cleaned water now moves into the WPA. Next slide, please. The WPA is really just a series of filters, sensors, and separators, and it removes contaminants, some particulates, but mostly organics, odor-causing contaminants, oxidation products, and so it basically just purifies that distillate from the distillation assembly, and then it adds iodine at the end. And so that entire process, like I said, is basically a rack and a half. And once the iodine is added, it is now potable water. Next slide, please. So our issue is with this menstruation concern is, does urine from a menstruating female crew lead to heavy particulates like blood clots? And if it does lead to these particulates, will that cause solid buildup and clogged hardware in any of the rotating equipment in the WHC, UMS, or WMS, UPA, or WPA? Next slide, please. And that might seem like some sort of an academic exercise, but unfortunately it is not. About a year into operation of this whole assembly, we found that we had a higher urine calcium concentration than expected from ground operations and testing. And we failed the distillation assembly. So we had to replace serial number 2 and went into a long, drawn-out 7-year actual testing, verification, validation process. And during that time, we were only reclaiming up to 70% of the water in the RFTA. So a large percentage of water in the urine was being discarded while we troubleshot. And eventually we found that changing the pretreated urine fluid from sulfuric acid to phosphoric acid would increase the calcium concentration in the RFTA, and reclamation efforts could resume up to 85%. And that's what we do now. So we change the pretreated urine concentration solution, and that is done actually in the US side, not on the Energia side. And now we can go up to 85%. Actually, from testing done on the ground, we could probably go up to 90%, but there's a concern that the urine tested is not perfect surrogate for on-orbit urine. And so they've backed off from that 90% reclamation rate to 85% simply to mitigate any additional calcium risks. Next slide, please. So in order to, well, I guess due to this concern for precipitation of solids, urine from menstruating females was not reclaimed on ISS, but was discarded. So the concern was that this blood and products of menstruation would likely cause precipitation. So to that end, engineers at Marshall did some tests, and they really put the system through the ringer. They actually reclaimed up to 90% exclusively on urine from menstruating females, and they found samples were pre-treated, filtered, and rotary equipment or rotary evaporated with a target of 90% water recovery. The water recovery ranged from 90 to 90.7 with no visible signs of precipitates or solid formation after initial and final observation. And based on this study, they found that current hardware systems are perfectly safe to operate using urine from menstruating females with no adverse effects to the system. So I thought that was fairly good news. There's really no reason why menstrual urine can't be used. Next slide, please. And this is a slide to just show some of the mitigating steps done. This is a critical day filter used on the urine funnel, and just an attempt to remove some of the larger particulates that go into the rotating equipment. And now back to you, Dr. Blue.
Okay, so I realize we're running close on time, so we're going to get through the next slides very quickly. But, one final thought on this, just to be clear, urine collection and water reclamation continues at this time during menstruation. We do reclaim water on orbit right now for menstruating females and reclaim it. Oh, I cannot do this. Okay, so last couple of slides discussing, some of the things we talked about today. One of the goals here today is not just to talk through some of these issues, but to dispel some of the commonly held beliefs or myths about menstruation on orbit and, concerns about this as we go forward. I would be amiss to not at least mention pharmacogenetics and pharmacogenomics, as this is often brought up anytime we do discuss the use of medications in flight. Could we tailor them to individual, genetic predilection towards a certain response or individual genetic polymorphisms? For example, could we use some sort of pharmacogenetics or genomics to determine appropriate choice of anticoagulants in the case of VTE? As I've mentioned previously in this presentation, there's a lot we don't know about pharmacy in space, including even simple use or effectiveness of medications, not to mention pharmacodynamics, pharmacokinetics, some of these additional issues that we've just not collected sufficient information on. I think the point of view that I would take at this stage is that while this is an interesting topic to discuss, the use of tailoring methods for specific medications to specific crew members, it's worth stating that we need a lot more information to determine appropriate forward formulary before we get down into the weeds of tailoring to individual genetic polymorphisms. So again, back to this issue of dispelling or pointing out some of the knowns or unknowns or the myths that have been kind of commonly perpetuated. Here's what we know. We know that multiple forms of contraceptive pills, IUDs, and implants have been flown and used without difficulty. There have been no reports of ineffective medication or poor response, no reports of associated adverse events. We also know that the risk of pregnancy is non-zero, and any discussion of use of hormonal modality should also be a discussion of contraception, particularly for longer duration mixed-sex crews. We also know that schedules will be busy. Mission and operation tempos are going to keep our crew members busy, and daily dosing may not be perfect. However, again, it's worth reiterating that despite these pressures, we have had no reported ineffective medications from scheduling constraints or otherwise reported in all of our experience using these medicines during flight. Identifying best therapy, again, is going to be highly specific to individual needs, and maintaining crew member autonomy and weighing in on this decision is important. While we discuss a lot of the risks that we need to take into account here, there are many ways that we can mitigate some of these hormone-related risks before flight. We should be testing for thrombophilias. The presence of an inherited thrombophilia does change the risk profile of using some of these modalities, particularly before long-duration flight. If we choose to use combined oral contraceptives, starting them before flight by at least 3 months, preferably over 12 months, does decrease many of these risks compared to starting or changing medicines just before flight. Similarly, with the IUD, placing it greater than 6 weeks, preferably greater than 12 months before flight, decreases the risk of possible complications or migrations, and further confirming locations with ultrasounds before flight can further reduce risks. Some of the myths we're trying to dispel, some of the high numbers that we've planned to previously for onboard product needs, while we admit that conservatism is very appropriate here, we never want to be lacking products that we need. Conservatism is appropriate, but grossly overestimating numbers by such a wide margin can limit other onboard resources detrimentally for the future crew and vehicle. The myth that toilets cannot handle blood. While again, unrestricted flow of menstrual products, particularly clots or heavy cellular or mucus components into the WMS is not going to be recommended. Flow of normal menstrual blood that is not otherwise contained by sanitary products or filtration is acceptable and is currently practiced. This thought that SANS may be influenced by combined oral contraceptives, implants, or IUDs, there is no evidence to suggest a causal relationship between hormonal use and syndromes of elevated intracranial pressure. There's a myth, sorry, there's a hot mic.
I'm trying to listen to aerospace medicine grand rounds and
There's
this meeting.
very good
grand rounds.
Can we please all check our mics? Thank you. There's a sometimes reported myth that IUDs are more likely to migrate or perforate in microgravity because they might float out of place. We have previous experience demonstrating that IUDs are stable for use in spaceflight. What do we need to know more about? We've touched on all of these things, so I'll keep this brief, but in general, we do not have a lot of quantitative input regarding actual menstrual output or length of the menstrual cycle in space, actual use of products quantified over time, and with or without the use of hormonal modality. The effects of microgravity on the menstrual cycle remain more or less unknown, aside from the fact that we haven't had major reports of a poor outcome or an adverse event associated with microgravity use of hormonal contraceptives or menstruation during flight. We've touched a lot on pharmaceutical stability, PK/PD, pharmacokinetics, pharmacodynamics, pharmacogenetics, and pharmacogenomics. All of these are fairly understudied, and additional information can certainly help in the future. Again, use of medications during spaceflight and effectiveness of those medications during spaceflight is an area that we have not historically collected a lot of data, and such data would be quite useful going forward. And finally, VTE pathophysiology and etiology are just now starting to really be studied. Any further information on this can certainly help inform some of these issues and risks going forward, and the future study is certainly warranted where these are concerned. I know we're a little bit out of time, but I would love to field any questions that the audience has. And again, just thank you very much for your attention and time this morning.
Dr. Blue, this is Ed Powers, and again, I want to thank all three of the speakers. If you don't mind hanging on just a second, I'll do some closeout things, and then maybe leave it open for questions if you're available to stay around.
Absolutely.
So first, thanks so much to the speakers, Dr. Blue, Dr. Steller, Dr. Zahner. This is an amazing topic. You've done an excellent job of going through it all. We really, really appreciate that presentation today. Also, thank you to all the participants. We often have the opportunity to have this sort of a discussion. And again, like I said, if you can stay after for questions, that would be wonderful. But I do want to have Rachel Fowler step in. Thank you very much, Rachel, as a coordinator of our aerospace medicine grand rounds. She has a few comments about continuing medical education and needs to show a slide so people get credit for it. And then we'll go back to our speakers in just a minute. So go ahead, Rachel.
Thank you, Dr. Powers. Can everyone see the slide with the code? Okay, I just want to remind everyone to text the number, enter in this event ID. You have until 11 p.m. today, and after that, then you will not be able to receive credit. And that's all for me.
Thanks very much, Rachel. And so Dr. Blue, Dr. Steller, Dr. Zahner, I'm going to go ahead and let you entertain questions for as long as you're available. Thanks so much. Are you able to, I don't know if Dr. Blue, if you're able to see the hand raising, I'm going to ask people to do a hand raising so that we can see them.
I should be able to. I'll start scrolling through and looking for that.
So far, I don't see any hands raised, but if anyone has a question, please raise your hand and we will recognize you.
And apologize that we went a little bit over. It's always a little bit hard to estimate the exact time with 3 speakers, but I appreciate everybody's patience.
Okay, I'm seeing a number of comments in the chat room saying thank you for the presentation and such, but so far I don't see anyone asking question. Wait, here we are. Hi, Dr. Anderton.
Hi, Dr. Powers, thank you. Firstly, thank you to the panel for some really excellent talks, and hello from London. I had a question, Dr. Blue. I wondered whether, with regards to the monitoring of medication for future missions, we obviously saw an increased documentation of the use of medication rather than actual increased use in medication. Is this something that will continue being monitored as we move forward? And is there a concern that crew are perhaps less likely to report it if it isn't monitored, as a means of how well they're doing in space, and whether that might be that might count negatively, if you like, towards them on the mission?
That's a really great question. So, it has been noted that the dose tracker project did demonstrate, a lot more data that would be available if we continued to monitor such things. And I think that's been met with a lot of continued interest. I don't know of specific plans for future monitoring, though I suspect that that will continue. I don't actually believe that the lack of reporting represents any, hesitation of reporting on the crew member side, just more of an operational tempo that diverts their attention and, focuses crew members on other activities rather than recording and reporting of medication usage. Just like if we asked you every time you took a Tylenol medication at home, for example, to write it down and report it to your doctor, we would be met with some limited success. It's the same sort of thing. When crew members use medications in flight, they don't necessarily think immediately to write it down and report it at their next medical conference with their physician. So it's simply a lack of opportunity in many cases, or a diversion of attention to other more pressing needs.
Thank you.
Okay, we're still open for questions if anyone would like to raise their hand or even speak up if you like, either way.
We'll take no questions as a good sign that we answered them all during the presentation. I think all 3 of us are quite happy to field questions individually as well. You're all welcome to reach out after this presentation directly to us. We are happy to field any further questions. And again, thank you so much for your time.
Thank you. Really appreciate the team and the effort that went into this. It's an amazing topic. We look forward to maybe having a follow-on at some point in the future as well. Thanks so much.
Sounds great. Thank you.
Thank you.
With that, we'll go ahead and end this session. Thanks very much again to all the participants. We appreciate your participation. Bye-bye.